Hello and welcome to my channel Magic of Medicine. Today we will discuss about Köhler's disease. Köhler's disease is an eponym for avascular necrosis of the navicular bone of the foot in childhood. Remember, in childhood, because its adult counterpart is not Köhler's, it is Muller-Weiss syndrome. So remember this avascular necrosis of navicular bone of foot in childhood is Köhler's disease and in adult it is Muller-Weiss syndrome. Now coming to the epidemiology of Köhler's disease. Köhler's disease occurs more commonly in boys than girls. However, the age of presentation is reverse. It appears before in girls than in boys. In girls, it is seen in less than 4 years of age, and in boys, it is seen in less than 6 years of age. Now, coming to the most important part, that is the anatomy of navicular bone. To understand the pathophysiology behind Köhler's disease, you need to understand the anatomy and the vascular supply of navicular bone. So, coming to the anatomy of navicular bone. Navicular bone is a boat-shaped bone of foot. It plays a crucial role in body weight bearing, adduction and abduction of midfoot, and maintaining the medial arch of the foot. So here's the diagram of foot, which shows calcaneum, talus, navicular bone, 3 cuneiforms and 1 cuboid bone, and then metatarsals and phalanges. Now again take a look at this diagram. You can see the navicular bone as a boat-shaped bone sandwiched between talus and calcaneum. Remember this thing. Navicular is sandwiched between talus and calcaneum. Now coming to the vascular supply. It is supplied by dual arteries. The dorsalis pedis artery, which supplies the lateral aspects, and the branch of posterior tibial artery, which supplies the medial aspects. Based on this supply, it can be divided into 3 regions: medial, central, and lateral 1/3 of navicular bone. The lateral aspect, as I told, receives blood supply from dorsalis pedis artery. Medial aspects receives supply from branch of posterior tibial artery, and the central zone. Remember, the central zone hence is watershed zone, and hence it is blood compromised zone or relatively avascular zone, hence more prone to avascular necrosis. Now remember this diagram thoroughly. Again revising the vascular supply of navicular, look at the lateral aspects. It is supplied by the dorsalis pedis artery. On medial aspects, it is supplied by posterior tibial artery, and the central 1/3, focus on the central 1/3, it is the watershed area. Now the second quoted theory is the ossification process of the bone. The navicular bone is the last bone to ossify in the foot, with multiple ossification centers, which makes the bone further susceptible to the effects of weight bearing and trauma. And the ossifications appear even later in boys than in girls, hence being the cause behind the girls being affected in earlier years than in boys. Remember, I have told you initially the epidemiology that the Köhler's disease appears in girls in less than 4 years and in boys 2 years later, that is less than 6 years. So, when the examiner asks you the pathophysiology behind Köhler's disease, you should tell the first reason is the dual vascular supply, making the central zone, which is the watershed zone, more susceptible for avascular necrosis. And the second reason is the late ossification of navicular bone, because of which it is bound to be compressed between the already ossified talus and calcaneum bones. Now coming to the clinical features. The patient will present with pain and swelling over the area of navicular bone, which is the dorsomedial aspect of the foot, and also the patient will have limping gait. Now, with these clinical features, your next investigation will be X-ray foot. So, on X-ray foot, you will see small and thinned out navicular bone, irregular or wafer-like in shape, and sclerotic and hyperdense in appearance. It can also show fragmentation with loss of trabecular pattern, and surrounding soft tissue swelling can also be seen. Now I am showing you the foot X-ray of Köhler's disease. So look at the navicular bone. Since you know the anatomy, you know the location of navicular bone now. Now look at the navicular bone. What has happened to it? Comment on its size, shape, appearance, and surrounding tissue. So navicular is reduced in size, irregular in shape, and is sclerotic in appearance. Now, since you have diagnosed the condition, you need to know the treatment options. So, you will have to prescribe NSAIDs for the symptomatic treatment, that is pain and swelling, and below knee cast for 6 weeks. So, this was all about Köhler's disease. Now, coming to the question answer session. So, the examiner will hand over a X-ray film of the foot and ask you to diagnose the condition. Now you will able to diagnose the condition. I have told you the typical appearance and the typical pointers like size, shape, and appearance. You will see that navicular bone has reduced in size, is irregular in shape, and appears sclerotic with loss of trabecular pattern with or without fragmentation. Now, since you have diagnosed the condition, the next question examiner can ask is, what's the adult counterpart of the disease called as? So you need to tell that the adult counterpart is Muller-V syndrome. Next question that can be formed is the epidemiology. So it affects more in boys than the girls. However, the age of presentation is reverse. It affects girls in earlier ages than the boys. Third question the examiner will ask is the pathophysiology. So you need to tell both the pathophysiologies. First one is the dual arterial supply, making the central one third of navicular bone a watershed area and hence more prone to vascular compromise and avian. And the second theory is the late ossification of navicular bone. The navicular bone is the last bone to ossify in the foot and hence making the bone susceptible for the sandwich compression between already ossified calcaneum and talus bones. Next question the examiner can ask is the classic clinical feature. So the patient will come with pain and swelling over dorsomedial aspect of the foot and limping gait. And final question which can be formed here is, what are the treatment options? So NSAIDs you will remember easily. The extra thing which you need to remember is the below knee cast, and the duration for below knee cast is at least for 6 weeks, and the condition is self-limiting. It will heal on its own. Thank you for watching the video. If you found the video useful, please like, share and subscribe.